Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about breech presentation. So what we wanted to discuss today, the definition, epidemiology, types, positions, etiology, diagnosis, mechanism of labor in case of breech presentation, management of breech, and lastly, the maternal and fetal complication. So, what is the definition of breech presentation? It is a longitudinal lie in which the buttocks, with or without the fetal legs, form the presenting part of the fetus. As you see in the picture here, this is the buttock, the lowermost part of the fetus, and in this picture also the buttock and the legs beside the buttocks. So buttocks and the legs forming the presenting pool. What is the incidence of breech presentation? It differs. If it is full term, it constitutes 3 to 4%. If we are talking about the premature 28 weeks gestation or less, it constitutes 25%. So the incidence in premature is very high. It is more common in nulliparous women. External cephalic version from 37 weeks cause decrease in the incidence of the breech presentation and also decrease the elective cesarean section due to breech. A reduction in planned vaginal breech birth followed publication of the Teen Breech trial in 2001, in which the investigators reported that delivery by planned cesarean section resulted in significantly lower perinatal and neonatal morbidity and mortality. And actually, this study made changes all over the world. And from this trial, TBT trial, Teen Breech trial, different centers all over the world recommend to do cesarean section in case of breech presentation. But this is changing nowadays with the recommendation of the Royal College and the American College recently. So we wanted to know how is the breech delivery, and it is very important for all obstetricians and all medical students to know the steps of vaginal birth in case of breech presentation, and the obstetrician should have the skills to do all maneuvers needed for delivery of breech. So, vaginal breech birth increases the risk of low Apgar score and more serious short-term complication, but not the long-term complication as mentioned by the Royal College of Obstetrician and Gynecologist. And emergency cesarean section is needed in approximately 40% of women planning a vaginal breech birth. What about the perinatal mortality? If we compare breech more than 39 weeks gestational age with vaginal delivery and elective cesarean delivery, and also with cephalic presentation delivery, we will see that 0.5 in 1000 with elective lower cesarean section for breech. This is the perinatal mortality, 0.5 in cases who did elective cesarean section, 0.5 per 1000. While in planned vaginal breech birth, it constitutes 2 per 1000. While in cephalic presentation, it constitutes 1 in 1000. This means that the vaginal births carry a higher perinatal mortality. Yes. But is this an actual mortality, or there is underlying causes rather than the delivery itself may be the cause of this mortality or this increased mortality? And if we choose and select the proper patient valid for vaginal delivery, the mortality will decrease both perinatal and neonatal. Let us see. Okay, so what is the types of breech? We have complete breech and incomplete breech, and the incomplete breech can be frank breech, footling presentation, and the knee presentation. Please look to this picture. Complete breech, the fetus present with buttocks and fetal legs beside it, and there is flexion at the hip and flexion at the knee. That's why we call it complete. Okay? Incomplete means incomplete flexion. As in cases with frank breech, in this picture, there is extension at the knee and deflection at the hip. And in footling presentation, in which there is partial extension at the hip and the knee, and in knee presentation, in this picture, where is extension at the hip and deflection at the knee. So the knee is the presenting part of the fetus. So this is the complete breech, this is the frank breech, this is the footling presentation, and this is the knee presentation. Complete breech constitutes 10%. The fetus assumes an attitude of flexion where the hip and the knee are flexed as in this picture, and the fetus present with buttocks and the legs beside it. This is the other varieties of incomplete breech, frank breech, which constitutes 65%. And as we mentioned, the hip is flexed while the knee is extended. Footling presentation, one or both legs, partial extension of the hip and the knee joint. Knee presentation, knee present first due to extension of the hip and deflection at the knee. What are the positions of the breech presentation? The denominator here is the sacrum. So where is the sacrum? Position means relation of the back of the fetus to the anterior abdominal wall of the mother, whether anterior, posterior, to the right or to the left. So all these are varieties in the position. This is left sacroanterior, this is right sacroanterior, this is left sacroposterior, this is right sacroposterior, and if it is direct anterior or direct posterior or transverse, right or left. Sacroanterior is the commonest. Why sacroanterior is the commonest? Because the concavity of the fetus fits into the convexity of the maternal spine. That's why it is commoner. Sacroanterior. What is the etiology? The etiology may be idiopathic, but there are some maternal causes and the fetal causes. Maternal causes related to the contracted pelvis, pelvic malformations or abnormal shape pelvis, pelvic tumor, congenital anomalies of the uterus, placenta previa, and the laxity of the maternal abdominal wall. While the fetal causes include prematurity is the commonest etiology, twin pregnancy, aneuploids, and the fetal neuromuscular disorders, because the fetus can't, the tone of the muscles of the fetus is weak, so the fetus can't turn. Malformation like hydrocephalus, intrauterine fetal death, intrauterine gross restriction, extended legs, polyhydramnios and oligohydramnios, both of them can cause breech presentation. Polyhydramnios because unstable lie and presentation, and oligohydramnios because little liquor don't allow the baby to turn. Short umbilical cord is another fetal cause. How to diagnose a case with breech presentation? From history, the patient may give history of previous breech delivery and repeated premature or breech delivery. Also, the patient may feel a lump in the upper abdomen, which is the head, occupying the upper part of the uterus. During examination and inspection to the abdomen, we may see transverse groove, which represent the area between the head and fetal limbs. This area can be seen on the abdomen as a groove above the umbilicus. Also, in thin patient, we can see localized bulge in the upper abdomen related to the head. By palpation, by superficial palpation, we can feel this supraumbilical groove. Also, we can find tenderness over the lump in the upper abdomen. Deep palpation by Leopold maneuvers, fundal grip will feel the head occupying the fundus with the criteria of the head: hard, round, tender, palatable, smooth surface. Okay? Umbilical grip to know the back of the fetus. Where is the back of the fetus? Is either near or away from the middle line according to the position. First, pelvic grip to find the presenting part in the lower uterine segment. We will find the criteria of breech, which is soft, irregular, not palatable, not tender, and large. Where can we hear the fetal heart sound? Auscultation of the fetal heart sound above the umbilicus on one side, mostly. By vaginal examination, the presenting part is high, soft, and irregular, no internal allotment. Movement of the lower limb can be felt through the anterior fornix. Ultrasound, of course, as you see in the picture, confirms the diagnosis. We will see the head in the upper part of the uterus, while the buttocks is down in the lower uterine segment. So the baby is longitudinal lie, but the buttocks is the lower pool and the head is the upper pool. Also, we can detect the fetal viability, also the biparietal diameter and the head circumference, because it is important. Because if there is a large head, like hydrocephalus, it is contraindicated for vaginal delivery, for example. Also, if the head is flexed or extended, also extended head make a risk for vaginal delivery. The head should be flexed. Okay? So we can diagnose if the head is extended or flexed, and if the head is normal size or enlarged. Also, we can detect the placental site, and if there is placenta previa, low-lying placenta. Also, the amount of liquor, is it oligohydramnios or polyhydramnios or normal? Is there any multiple pregnancy or single baby? So we can detect also the congenital anomalies other than hydrocephalus, like meningocele, meningoencephalocele. Any congenital anomalies can be detected, sacral tumor. What about frank breech? Frank breech is very special. The fundal level is low due to early engagement and restriction of allotment of the head. Because of the splints, the legs act as a splint around on both sides of the head. Okay? Breech feels small, as in this picture, regular, more firm, and they may give allotment. Combined grip may be used to differentiate between occipital posterior and frank breech, where the head can allot in the first case. Fetal heart sound can be heard below the umbilicus. Why? Because we said that there is engagement, early engagement of because the lower pool is small, because the legs is not beside the buttock, the legs high up, act as a splinter beside the head. So early engagement happen. So fetal heart sound can be heard below the level of the umbilicus, not like the complete breech. Failure of external cephalic version because of this splint of both legs. Ultrasound can confirm, of course, the diagnosis of frank breech. Okay, let us continue. During labor, as regard breech presentation, before rupture of membrane and after rupture of membrane. Before rupture of membrane, while the membrane is still intact, cervix is thick, not fully dilated, the membrane sausage shape. The presenting part is high, irregular, with fetal limbs, can be felt. We should exclude the presence of cord presentation because it is very important. What about after rupture of membrane? This is the cervix and this is the presenting part. Meconium may stain the examining finger. We are close to the anus, so meconium can come and stain our finger during BV examination. We will not feel any fontanelle or sutures because it is not hid. It is not the vertex, but it is breech. And we can feel 3 bony prominence. Look to this picture, please. 2 ischial tuberosities, 1 in each side, and tip of the sacrum. So we feel 3 bones, ischial tuberosities and sacrum. Okay, and 1 opening, which is the anus. And this should be differentiated from face presentation, because also in face presentation there is 3 bone, 2 maxillary bone, and the chin. So this is 3 bone and an opening, which is the mouth. And if accidentally you put finger inside the mouth, there is suckling in case of face presentation. But this doesn't mean that when you examine a case suspecting breech, don't put your finger inside the opening. You do injury to the anal sphincter. So don't put your finger inside the opening. But you will feel the ischial tuberosities and sacral and the sacrum, and you can detect the position, is it sacro-anterior or posterior, and so on. Late in labor, you can feel the presenting part and the dilated cervix, and you can measure this dilatation of the cervix, is it 4 centimeter, 8 centimeter, and so on, so till it becomes fully dilated. So the differential diagnosis of breech presentation include face, as we mentioned before, and the face also characterized by the supraorbital ridges, nose, and alveolar margin. Also, for differential diagnosis, fetal malformation like anencephaly. Also another malpresentation, which is shoulder presentation, and compound or complex presentation, in which one fetal limb beside the head, like hand beside the head, and of course we can differentiate hand from foot by the presence of long fingers in the hand and short toes in the foot, and the presence of heel in the foot. Let us go to the mechanism of labor. According to steps, the buttocks first will be delivered, and the buttocks will be engaged inside the pelvis by trochanteric diameter, which is 10 centimeter. Look to this picture. This is the steps of delivery. Bitrochanteric diameter enter through the oblique diameter, which is about 12 or 12.5 centimeter. Descent, then engagement, then reaching the pelvic floor, and like occipital anterior, when the buttock reach, the anterior buttock reach the pelvic floor, it will rotate its circle anterior, and the anterior buttock hang behind the symphysis pubis, as you see here. Okay, the posterior buttock delivered first, followed by the anterior buttock by lateral flexion of the spine. So the posterior, then the anterior buttock. So descent, engagement, reaching the pelvic floor, 8 circle internal rotation anterior, then hang behind the symphysis pubis, then delivery of the posterior buttock by lateral flexion of the spine, and then anterior buttock. What about the shoulder? The shoulder has the bisacromial diameter, which is 12 centimeter. Descent also, as you see in the picture, in the same oblique diameter of the pelvis as that of the buttock, in the same oblique diameter of the pelvis. Then reach the pelvic floor, then rotate its circle anterior. The anterior shoulder impinges under the symphysis pubis, as you see here. Then the posterior shoulder is delivered, as you see in this part, then followed by the anterior shoulder. What about the aftercoming head? The head is slightly deflected, that's why the engaging diameter is sub-occipitofrontal, which is 10 centimeter. It entered the pelvis in the opposite oblique diameter of the maternal pelvis. So the buttocks and the shoulder in the same oblique diameter in their descent and engagement, while the head descend and engaged in or go through the pelvis in the other oblique diameter or the opposite oblique diameter. Then the head will rotate when the occiput reach the pelvic floor, 8 circle anteriorly, then occiput impinges behind the pubic arch here, as you see here, the occiput behind the pubic arch. Then the head is delivered by flexion. And this presentation, breech presentation, is one of the cases in which the head delivered in flexion, because all of us know the commonest presentation, which is occipital anterior, the head is delivered by extension. But in aftercoming head in breech and in phase to pubis in direct occipital posterior and in phase presentation, the head is delivered by flexion. Okay? Okay. The course of labor in first stage may be prolonged, may be some inertia, sometimes premature rupture of membrane and the prolapse of cord, and of course prolapse of cord is an emergency situation. Second stage, buttocks usually no difficulty, if no disproportion, and also the shoulder easy unless arm extended, and we'll see the complicated breech how to be delivered later on. Head usually need assistance from the obstetrician. Sonography is important, as we mentioned before, can confirm diagnosis, can detect the fetal weight, can detect the fetal head attitude, is it flexed or extended, which is very important, any congenital anomalies, also the type of breech, complete or frank breech, and so also the amount of liquor and the site of the placenta if there is placenta preview. Okay, the first line for treatment of breech presentation is to do external cephalic version. In external cephalic version, we try to convert breech presentation into vertex. As you see in the picture, one arm in the lower pool and one arm, one hand on the upper pool, trying to rotate the trunk of the baby so to become vertex presentation. And the success rate of external cephalic version is 40 to 60%, and should be offered after 37 weeks gestational age, after maturity of the fetus, till the time of delivery. You can do it during this period, after 37 till labor. The woman should consent for that. 1 in 200 external cephalic version attempts will lead to emergency cesarean section. That's why it should be performed by trained, experienced clinician, so to minimize the complication as much as we can and to get successful external cephalic version. Also, there is some prerequisite presence of continuous electronic fetal heart monitoring before and after the version, ultrasound available before and after doing the technique. Also, availability of emergency cesarean section if it is needed, if any complication happens. External cephalic version aims to decrease term vaginal breech delivery to avoid maternal and fetal complications. And all the guidelines recommend to do or to counsel the patient to do external cephalic version. The patient is given tocolytic drug like terbutaline subcutaneous before the procedure by 30 minutes. So the uterus is relaxed during the maneuver. If the patient is Rh negative, give anti-D. Don't make more than 4 attempts of external cephalic version for a suggested maximum time of 10 minutes in total. So you have a 10 minutes and you have only 4 attempts. Then do CTG monitoring. What is the contraindication to do external cephalic version? If there is placenta previa or accidental hemorrhage or ruptured membrane or congenital anomalies or current or recent vaginal bleeding or sensitized Rh negative patient or abnormal fetal Doppler or preeclampsia or abnormal CTG or lack of equipments or trained personnel or lack of capability to perform cesarean section if it is needed as an emergency if complication happen. Emergency management, urgent delivery by cesarean section should be done if abnormal CTG was found or vaginal bleeding or unexplained pain. Okay? Okay. Any alternatives to external cephalic version? There is some trials of using moxibustion, which is burning herbs, stimulate acupoint, as you see in the picture here, located outside the outer corner of the fifth toenail, or acupuncture, stimulation of the fifth toe and the auricular points, or postural techniques like passive bridge, knee chest position as in the picture, but actually there is no evidence of these maneuvers to be successful as external cephalic version, but you can consider it as an alternative. Of course, moxibustion and acupuncture is Chinese origin of this maneuver, and there is some researches about these maneuvers. Okay, what about Caesarean section? Caesarean section in the past 20 years was commonly used everywhere in case of breech presentation because of TBT trial which was done and published in 2001, which recommend to do Caesarean section to decrease the perinatal fetal mortality and neonatal morbidity and mortality. So this recommendation make many centers encourage doing Caesarean section in case of breech presentation. But actually this is not the right indication for breech presentation, because if you select the patient properly who is candidate for vaginal delivery and you did a plan for vaginal birth and you have all the prerequisites needed, you will have successful vaginal breech delivery. And this is the recommendation of the Royal College of Obstetricians and Gynecologists recently about the breech presentation. So current recommendation for breech presentation at term include offering external cephalic version to those patients that meet criteria, and for those whom are not candidate or decline external cephalic version should be counseled on the risks and the benefits of planned vaginal breech delivery versus planned cesarean section. So the patient should know the risks and the benefits of both methods or routes of delivery. Is it either vaginal or cesarean? Because also cesarean section carry complication being an operation itself or being later on a next pregnancy, risk of being vaginal after cesarean section, or complication of repeated cesarean section, or complication of abnormal placental invasion due to presence of a scar in the uterus of this cesarean. So also cesarean section carry its risks. So you should balance the risk and the benefit of each procedure. So selection of appropriate pregnancies and skilled intrapartum care may allow planned vaginal breech birth to be nearly as safe as planned vaginal cephalic birth. For favorable attempt breech delivery, national guidelines and criteria for the management of term breech presentation should include obstetric history, estimated fetal weight less than 3.8 kilogram, non-hyperextended head on ultrasound, no evidence of antenatal fetal compromise and adequate mother pelvis, and no other contraindications like fetal anomaly and so on. Women should be informed that cesarean section increases the risk of complication in future pregnancy, like risk of vaginal birth after cesarean, increased risk of complication at repeat cesarean, the risk of abnormal invasive placenta as we mentioned before. Delivery must be in a hospital under supervision of trained specialists, senior staff with facilities for immediate cesarean section if needed, anesthetist and trained assistant and the neonatologist should be available all the time. Appropriate analgesia given to the patient. Try to avoid premature rupture of membrane by avoiding high enema, rest in bed, avoid frequent vaginal examination. During the first stage, ascertain the degree of cervical dilatation, exclude cord presentation, verify type of breech, and examine the pelvic capacity and do pelvimetry, clinical pelvimetry. What about the effect of epidural anesthesia? Epidural anesthesia can carry risk because it is likely to increase the risk of intervention, and the patient who take epidural anesthesia will not try to push down or will not be able to push down, so we will lose this force because of epidural anesthesia. So this may let the doctor to interfere early in delivery of the breech and breech extraction. Then the second vaginal examination after rupture of membrane, you should exclude, don't forget, the prolapsed cord and detect the how many centimeter is the cervical dilatation. Fetal heart sound should be frequently auscultated. We recommend the electronic fetal monitoring. Induction of labor is not usually recommended in case of breech presentation as recommended by the Royal College. While augmentation can be used like oxytocin infusion if the contraction frequency is low in the presence of epidural analgesia. In the second stage, the position of the patient may be semi-recumbent as in this picture or all fours position, but some doctors cannot do the delivery in this position, so the patient will change her position to the semi-recumbent position because the maneuvers, the very special maneuvers of delivery in breech need the patient to be on semi-recumbent position like that. Management also include adequate descent of the breech in the passive second stage is a prerequisite for encouragement of the active second stage. So you should note that in the passive second stage there is descent of the breech, and this is a good sign. Okay, a passive second stage to allow the descent of the breech to the perineum prior to active pushing is recommended. So you let the breech to descend until reach the perineum. Then you ask the patient to bear down after that. If the breech not visible within 2 hours of the passive second stage, cesarean section should normally be recommended. Okay, as you see in the picture, this is the descent of the breech till reaching the perineum and getting out. While involuntary pushing may occur earlier, encouragement of maternal effort shouldn't start until the breech is visible. Once the buttocks have passed the perineum, significant cord compression is common. Traction should be avoided. Hands-off approach is required. Try to be patient as much as you can, but with appropriate and timely intervention if progress is not made once the umbilicus has delivered or there is poor tone, extended arms or extended neck. All these require intervention and you should take a decision. Tactile stimulation of the fetus may result in reflex extension of the arm or head and should be minimized. Care must be taken in all maneuvers to avoid fetal trauma. Fetus should be grasped around the pelvic girdle, as you see in the picture. Place the thumb on the sacrum and the other finger on the anterior iliac crest. This is how to hold the baby. Don't hold the baby from soft tissue, only from the pelvis, hip bone, and sacrum. Okay? So, you hold from this bone, not from soft tissue, so not to injure any organ. And the neck should never be hyperextended. This is very important also. And also, always keep the back anterior. The back of the fetus should be upward or anterior all the time during the delivery. Signs that delivery should be assisted include lack of tone or color or delay, commonly due to extended arms or an extended neck. In general, intervention to expedite breech birth is required if there is evidence of poor fetal condition or if there is delay of 5 minutes from delivery of the buttocks or to the head, or more than 3 minutes from the umbilicus to the head. Okay? So you should wait the baby descend spontaneously, don't interfere. But if you found change in color of the baby or the tone, or there is delay in time, 5 minutes from delivery of the buttocks to the head, or past this minutes, or more than 3 minutes from umbilicus to the head, so you should interfere. Management of second stage also, if the back start to rotate posterior, gently rotate it to keep it anterior or upward. All the time should the back of the baby should be up or anterior. Once the scapula is visible, the arms can be hooked down by inserting finger in the elbow and flexing the arm across the chest, or if nuchal lofts maneuver is advised, as we will see later on. Delivery of the head achieved by 3 different methods. 2 of them recommended: jaw flexion shoulder traction or Morse-Smilovit method, or using forceps, paper forceps, and the third one is not recommended nowadays because it may be injurious to the neck of the fetus by lifting the baby from legs toward the mother abdomen, but possible extension and injury, so it is not preferred. So the preferred one is jaw flexion shoulder traction or use of paper forceps. What about the preterm? Is all preterm need to be cesarean section as in this picture? No. Routine cesarean section for breech presentation in a spontaneous preterm labor is not recommended, as mentioned and reported by the Royal College of Obstetricians and Gynecologists. The mode of delivery should be individualized based on the stage of labor, type of breech presentation, fetal well-being, and availability of an operator skilled in vaginal breech delivery. And this is very important. The skilled obstetrician who can do the maneuver. Planned cesarean section is recommended for preterm breech presentation where delivery is planned due to maternal and or fetal compromise. So this is the indication of cesarean here, either maternal or fetal compromise. Management with an unplanned vaginal breech labor. Suppose you are in the hospital and a patient came to you in the emergency department with breech presentation and you don't know about her before, and even she don't know that she has a malpresentation. What you are going to do? So management should depend on stage of labor, whether factors associated with increased complication are found, like what? Hyperextension of the fetal head is a risky factor. Low estimated weight, less than 10 centile, may be also a risk factor. Footling presentation is high risk factor. High estimated fetal weight, more than 3.8 kilogram. Or there is evidence of antenatal fetal compromise. So all these factors will affect your decision. Availability of appropriate clinical expertise and equipments, and the availability of CTG, operative theater, all measures for cesarean section if needed. So all this is present or not. And lastly, the informed consent from the patient. Where time and the circumstances permit the position of the fetal neck and the legs and the fetal weight should be estimated using ultrasound, and the woman counsel as with planned vaginal breech birth. Women in active second stage of labor shouldn't be routinely offered cesarean section. If the, 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 the woman was in second stage, don't do cesarean section as a routine, because you can do vaginal delivery so long as there is no risk. So we can now summarize the delivery of breech into management of uncomplicated breech delivery and the management of complicated breech delivery. For management of uncomplicated breech delivery, we have 4 types. Spontaneous breech delivery, the doctor never interfere, maybe happen without attending a doctor, and this is of course dangerous and a carry complication. This is spontaneous breech delivery. Assisted breech delivery in presence of obstetrician, trained one, who will assist in the delivery of the shoulder and the aftercoming head, not under anesthesia. Okay? Or partial breech extraction, the obstetrician will help delivery of shoulder and aftercoming head, but under anesthesia. Or complete breech extraction, the obstetrician will do the whole process from the buttocks up to the head under anesthesia. So we call it complete breech extraction. This is the management of uncomplicated. So let us start with the spontaneous one. As you see in the picture, the baby descend, engage, and the buttocks descend. Then the shoulder descend, delivery of the shoulder. Then the aftercoming, the baby is hanged. Then anybody can hold the baby till the head is delivered in flexion. Okay? Complication of spontaneous breech delivery may be maternal exclusion, perineal laceration, fetal asphyxia, and trauma. Of course, it is not advised. Assisted breech delivery, as I mentioned before, the doctor will assist the delivery of shoulder, as in this picture, bringing down the arms, then delivery of the aftercoming head. As you see, the doctor insert 2 fingers in the cubital fossa to help flexion of the arm, then withdraw the hand in front of the chest of the baby smoothly and gently downward for both shoulders. Okay? Okay. So this is the delivery of the shoulder, as you see here. Also, this shoulder is delivered in this picture. Don't pull. Remember this point very well. Ask the patient to strain until the perineum. After the perineum, the breech reaches the perineum. Do episiotomy when indicated, as recommended by the Royal College. They said if it is indicated, do it, the episiotomy. Not as a routine. Not in all cases as a routine. When indicated. Okay? Then cover the baby with warm towel to prevent premature respiration. When the umbilicus outside, draw loop of cord to prevent compression of the cord against pelvic wall. Detect pulsation of the cord. Prevent entanglement of the cord. Okay? And don't forget, as we mentioned before, the time allowed. The delay shouldn't exceed 5 minutes from the buttocks to the head and the 3 minutes from the umbilicus to the head. Okay? Also, be careful about the tone of the baby, of the muscle of the baby, and the color. It's very important. Then the delivery of the shoulder, as I mentioned before, bringing down both arms. Always keep the back anterior. Don't forget this point. The back should be kept anterior all the time. During pains, apply gentle fundal pressure to guide the head in the pelvis. This is called Christeller maneuver, and it maintains flexion of the head. As in this picture, help to maintain flexion of the head because it is important for head to be in flexion, not in extension. Then coming the delivery of the aftercoming head. Okay, in uncomplicated breech. And we have 3 maneuvers. Either Morse-Smelvet maneuver, jaw flexion, shoulder traction, as in this picture, or forceps using pepper forceps, or Burns-Marshall technique. Let the baby hang it down until the lower hairline appear under the pubic arch, or the nape appear under the pubic arch, then hold the baby from legs toward the mother abdomen, but it is not preferred nowadays, this maneuver, for the risk of extended head. So the best method is Morse-Smelvet maneuver and pepper forceps delivery of the aftercoming head. Okay. In case of Morse-Smelvet maneuver, the body of the fetus is supported astride the left forearm with 2 fingers on maxilla, as you see in this picture. Then the other hand, 1 finger on the right shoulder, 1 finger on the left shoulder, the index and the ring finger on both shoulders, 1 in each shoulder, and the middle finger on the nape to support it and maintain flexion. Then the 2 finger on the shoulder will do traction. That's why we call it jaw flexion, because the left hand, the finger on the maxilla, 2 finger, 1 in each maxilla, stimulate the flexion of the head, while the other hand do shoulder tractions. That's why we call it jaw flexion, shoulder traction. Okay? Traction is carried out downward and backward, helped by suprapubic pressure until the nape of the neck delivered under the pubic arch. Then the body is lifted up over the mother abdomen to deliver the head inflection, as you see in this picture. What about Weber forceps? Also preferred method for delivery. Applied from ventral side, as you see, from the ventral side of the fetus to maintain flexion. Then the assistant left the fetus and apply traction. Okay, as you see in this picture and in this picture, this is Weber forceps for delivery of the aftercoming head in breech presentation to deliver the head in flexion. Last one is Burns-Marshall technique. The baby is hanging down, as we mentioned before. Then the hairline appear under the pubic arch. Then under the symphysis pubis. Then lift the fetus up toward the mother abdomen. But it is not advised nowadays due to concern of overextension of the fetal neck. What about the breech extraction? We finished the spontaneous breech delivery, assisted breech delivery. Then we have partial breech extraction and the complete breech extraction. Here the doctor do delivery for the shoulder and the aftercoming head under anesthesia. Okay? This is called Cox-Marshall maneuver. The infant is delivered spontaneously as far as the umbilicus, but the remainder of the body is extracted under anesthesia. Episiotomy is done under local infiltration anesthesia when breech distend the perineum when indicated. So episiotomy, as recently reported in guidelines, when indicated and not routine. Leave the breech delivered spontaneously until the umbilicus of the fetus appear. Anesthesia, general anesthesia is given, like siren tail by anesthetist. So anesthesia for a very short time. The arm delivered by hooking the elbow. Aftercoming head is delivered by the jaw flexion shoulder traction or Weber forceps. Complete breech extraction performed from the start. The whole breech will be delivered under anesthesia from the buttock up to the head. The indication may be maternal distress, fetal distress, prolonged second stage footing presentation while the cervix is fully dilated, prolapsed pulsating cord in a fully dilated cervix. So we are in a hurry, so the doctor should do the maneuver from the start. As you see in the picture, bringing down leg or groin traction in case of frank breech, or bringing down the legs in complete breech. Then look to this picture, please. This is called Benner's maneuver. 2 fingers in the popliteal fossa behind the knee. Make the leg to be flexed like that. Then hold it between the index and the middle finger and get it down outside. This is for when the legs are extended as breech with extended leg, which is the frank breech. While in complete breech, you can catch the foot between the index and the middle finger and deliver it under anesthesia. Okay, easy. But of course, it needs a trained obstetrician on breech delivery. This is again the complete breech extraction, as you see. All maneuvers as mentioned before, then delivery of the shoulder and the aftercoming head. Disadvantage and the complication of breech extraction: entanglement of the cord, fracture of the lower jaw, back rotates posterior, fetus delivered with the breast respiratory center, high incidence of postpartum hemorrhage, also the risk of anesthesia. What about the management of complicated breech? Complicated breech, like breech with extended legs, or breech arrested above the pelvic brim, so needs cesarean section from the start, cannot enter the pelvic inlet. Or breech impacted at the outlet, and this is a very big problem because breech descends through the inlet but impacted at the outlet. Or arrest of the shoulders due to extension of the arm or knuckle position, or arrest of the aftercoming head due to faults in the head or faults in the passage. So I gathered this complicated breech delivery: breech with extended leg, breech arrested above the pelvic brim, breech impacted at the outlet, arrest of the shoulder, arrest of the aftercoming head. What we are going to do in each one. Breech with extended leg, like this one, no interference. The breech will descend, and the patient, when the breech reaches the perineum, is asked to bear down. You can help by groin traction when indicated by finger, as in this picture. Bringing down a leg also can be used by pressure on the popliteal fossa and try to hold the foot and get it out. So either groin traction, which is more applicable and more used, or we may do cesarean section in frank breech if associated with post-maturity or suspected contracted pelvis or elderly prima gravida or other obstetric indication. What about if the breech cannot enter the pelvis, arrested above the pelvic brim? So we have no method for delivery except cesarean section. So we'll do cesarean section from the start. We are not going to give a trial for vaginal birth if the breech cannot enter the pelvis. So we will do cesarean section. This arrest at the pelvic inlet or brim due to disproportion or pelvic deformity or pelvic tumor or large fetus or pendulous abdomen. So arrest at the pelvic inlet and indication for cesarean section. Breech impacted at the outlet will be managed according to the cause. Locked to the causes, extended legs, large feet, outlet contraction, all of them, cesarean section is the best line of treatment. Uterine inertia, we can give oxytocin infusion and bringing down leg. Rigid perineum, we can do episiotomy. What about the problem of the shoulder, arrest of the shoulder, and the arrest of the aftercoming head? For the shoulder, we have two problems: extension of the arm and the nuchal position. Extension of the arm due to traction on the trunk of the breech during the delivery, particularly when the cervix is not fully dilated. And this is a mistake from the doctor who do traction on the trunk of the fetus while the cervix is not fully dilated. This is the cause for extension of the arm. And we ask all the time, don't touch the baby. Leave the breech to be delivered with until reaching the perineum, then descent in the pelvis, until reaching the perineum, then ask the lady to bear down. Okay? So don't interfere when it is not needed. The early interference from the doctor may cause complication. Okay? Okay. Nuchal position, dorsal displacement, as in this picture. Dorsal displacement of the arm, or the condition in which the forearms lies behind the nape of the neck. It is the result of rotation of the trunk in the wrong direction. Rotation of the trunk in the wrong direction makes this problem, which is the nuchal position of one or both arms. Okay? How can you manage breech with extended arm? By classic method, easily you can bring the posterior shoulder, posterior arm first through the sacral concavity because it is roomy. Try to bring the posterior arm, then try to bring the anterior arm. This is called the classical method. If you deliver the posterior arm, but you can't deliver the anterior shoulder from behind the symphysis, rotate the trunk 180 so the anterior shoulder will be posterior, and then deliver it as the first one. Okay, this is called the classical method. Another method, very interesting and of common use, Lafset maneuver. This is a method of choice, really. And this method, as in the picture here, we rotate the trunk 180 degree. Okay? Then we deliver the anterior shoulder. Then rotate another 180 degree in the reverse direction. And then the posterior shoulder become anterior, then deliver it as the first. The idea is the anterior pelvis is small, short, while the posterior is long. And the inclination of the pelvis help me also in this maneuver. The anterior shoulder is above the symphysis, while the posterior shoulder is below the promontory, as you see in this picture. The anterior shoulder above the symphysis, while the posterior shoulder below the promontory. Okay? Okay. And if these are reversed in position, the posterior shoulder will be below the symphysis, And this what we are going to do. If this shoulder, okay, rotated in this direction, this arrow denoting the direction of rotation. We rotate 180 degree or half circle, okay? So this posterior shoulder become anterior, then deliver the shoulder. Then rotate another 180 in the reverse direction. Then the posterior shoulder become anterior and deliver it. Okay? And always remember to keep the back upward. Always during the rotation, you should keep the back anterior. During bringing down the arm, we bring the hand smoothly in front of the chest of the baby, smoothly and gently, so not to cause friction. Nuchal position, as you see in this picture, the arm is behind the nape. We will rotate the trunk in the direction of the tips of the finger. Lock to this tip of the finger of the baby in this direction, right? So we should rotate in this direction, like that, the trunk. When rotate the trunk in this direction, this arm will change to be here till it becomes anterior in front of the chest of the baby. Then get it down. So the direction of rotation of the trunk will be in the direction of the tip of the fingers of the baby. So in this case, here. What if I have bilateral nuchal position? I'll do rotation for one arm first, the direction of tip of the finger of one arm first, to free this arm and get it down. Then rotate in the direction of the tip of finger of the other arm to get the other arm, if it is bilateral. If it is unilateral like this picture, so the rotation will be in this direction. What about if there is arrest of the aftercoming head? The cause may be related to the head or related to the passage. Large head. If the baby is living, you should do cesarean section or symphyseal. Dead baby may be cesarean section or craniotomy. Extended head will do jaw flexion, shoulder traction, Morse millipede method with suprapubic pressure by the assistant. What if the back, if you remember during the lecture all the time I am saying keep the back anterior or up. Here the back, the rotation of the trunk happen, so the back become downward or posterior. And this is wrong from the attending the delivery. Okay? Don't leave the trunk to rotate to become posterior or downward like that. This is a problem. Okay? So what we are going to do, first do jaw flexion, shoulder traction, but in reverse direction. Two finger on this maxilla, trying to flex the head, then shoulder traction and deliver the head in flexion towards the mother abdomen. If the head is extended, we use Bragg maneuver by lifting the baby, extended head and the back, posterior rotation of the occiput like this, posterior rotation of the occiput, elevation of the foot towards the mother abdomen called the Bragg maneuver. This is a line of three. What about if the problem for the arrest of aftercoming head is related to the passage? Maybe you contracted pelvis, living fetus, do cesarean section or symphysiotomy. Of course, this is very critical situation. Dead fetus, do cesarean section or craniotomy. If rigid perineum, episiotomy and forced delivery. If incompletely dilated cervix and the fetus is living, if you can slap the rim of the cervix above the fetal head, then do it. After that, do jaw flexion shoulder traction maneuver with suprapubic pressure. So try to push the cervix over the fetal head. If this rim can be pushed up the fetal head. But if it's still not fully dilated, you may do dorsal incision at 10 and 2 o'clock. Look to the picture, please. With scissor 1 to 2 centimeter. This is at 2 o'clock and this is at 10 o'clock. 1 to 2 centimeter incision. And another incision may be at 6 o'clock. And deliver the head. Then after delivery, we will suture this incision. Or do cesarean section and don't forget to do midline or vertical incision, not transverse lower uterine incision. In this case, we will do midline or vertical incision in the uterus if we are going to do cesarean. So either do dorsal incision, cervical incision, or do cesarean section. There are many indications for cesarean section in breech. Of them, the high risk cases of hyperextended fetal head, low estimated weight, less than 10 centile, footling presentation, high estimated fetal weight, more than 3.8 kilogram, evidence of antenatal fetal compromise, contracted pelvis, fetal anomaly, elderly prima gravida, more than 35 years, prolapsed pulsating cord and cervix not fully dilated, associated abnormalities like placenta previa, pelvic tumors, or uterine scar. So what are the complications? The maternal and the fetal. Maternal including obstructed labor, if in case of impacted breech with extended legs, or prolonged labor and maternal distress, or uterine inertia, or cervical, vaginal, or perineal laceration, or postpartum hemorrhage, or puerperal sepsis. Fetal complication like asphyxia, like intracranial hemorrhage, fetal loss, dislocation of the neck, shoulder, or hip, or injury to abdominal organ, or fracture of long bones and lower jaw, or intracranial hemorrhage and asphyxia. So, what about the debate surrounding the management of term breech presentation? There is a need for an individualized approach to the management of term breech presentation. The adequate management of term breech pregnancies requires screening, as we mentioned before, and identification of breech presentation at 36 gestational, followed by thorough evaluation of the fetal weight and the growth, a while obstetric history, antenatal gestational disorder, and pelvis size evaluation are considered. The management plan, including external cephalic version as recommended by the Royal College, and follow-up based on maternal and fetal condition and the potentially associated disorder, should be organized on case-by-case basis by skilled team obstetricians after the woman is informed and helped to make a decision regarding delivery route. So we recommend the planning for vaginal birth in case of breech presentation when this birth will not carry risk to the fetus and to the mother, and when we do all precautions needed before this plan for delivery. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.